This program is brought to you by Emory University.
All right, good morning. Thank you everyone for being here. As you can see, our speaker this morning is Dr. Jane Titterington. Jane started out at Kansas State undergrad, the purple and silver, and medical school, got her MD PhD from Tulane, and then interviewed and matched with our fast track, long track, fast track research pathway. Yeah, it's short then long, then short again. Where she did research with Dr. Bob Taylor in his lab, and is now in her second and final clinical year. And next year will be one of our heart failure our heart failure transplant fellow. As you can see, she could talk to us about stem cell therapy. Jane Titterington.
Thank you very much. I've told my Grady colleagues, because that's my usual Friday home, to give me a call if the audio isn't working, and I'll just put my speakerphone on. But thanks for having me. This is a topic I actually feel quite passionately about and have worked on for a couple of years now. And so I'd like to just give you a brief sort of bird's eye view, because I don't have time to delve in exquisite detail on a lot of these issues with stem cell therapies, but just wanted to hit some highlights, sort of what's been done, where we're going, what's in the pipeline. And some of course, because I'm a basic scientist by nature, just a little touch of some biology. Okay, I don't have anything to disclose, no conflicts of interest. So some of the things I want to talk about today, just briefly review some of the clinical trials, the early clinical trials that have support the use of stem cells, particularly following myocardial infarction. Understand a little bit of the basic biology and the properties of my favorite cell type, mesenchymal stem cells, that would make them an attractive therapy for regenerative medicine. And then we'll, throughout the talk about challenges and sort of gaps in knowledge and some of the barriers that there are to sort of bringing this to prime time. One of the ongoing jokes in cell therapy is that we've been about 5 or 10 years away from being able to deliver these things for about 20 years or more now. So some of the reasons why will be discussed. So when you think about the broader category, which is regenerative medicine, this is a GIF of or GIF, depending on how you say it, of a newt. And if you cut off the arm of a newt, it can grow back. And so the question is, why can't we have organs grow back or tissues grow back? Well, to some extent we can. We do have stem cells. We do regenerate things like our gut all the time, just in natural tissue turnover. And I guess if you're a baby and you lose a fingertip, there's a chance it could grow back. But obviously, as we age, our stem cell regenerative capacity goes down, and further, we're a lot more complicated and have a lot more cells than a newt. So some of you might have seen this picture and then thought about something like Star Wars. The reason this is in the talk is because, just to highlight that I think in regenerative medicine it's important to think beyond cells, but to think about how biomaterials and man-made technology can also help improve function. So that brings me to my points. Today's focus is, of course, going to be on cells, but I think it's important to note that in tissue engineering and regenerative medicine in general, cells are only one component of what I consider the triad. So cells are obviously key, but extracellular matrix and biomaterials and support for those cells is critical in regenerative biology, and also signals, be them cytokines, growth factors, chemical substrates, signaling second messengers, and so on. All three of these combine to sort of influence regenerative medicine. You might have seen pictures like this going around on the internet. This was from the late 90s, the Vacani mouse. So this isn't actually an ear growing on a mouth. What it is stem cells or cartilage cells and then some matrix so that you could have a nude mouse which has no immune system, and I'll talk about why that's important later, and just cartilage structure and cells. That the idea being in sort of simple connective tissue biology is that you would have a temporary artificial matrix, and then stem cells, as that matrix is degraded, stem cells would make their own new matrix, and then you regenerate simple tissues such as connective tissue. Obviously the heart is a little bit more complicated than cartilage. So I don't need to go into great detail with this audience, of course. Myocardial infarction, if you add up all of the new infarcts and silent infarcts and repeat infarcts, it's over 1 million Americans a year that have an MI. And we've done a great job with all of our medical therapies and revascularization in keeping these people alive. But nearly a third of them will go on to develop systolic heart failure within 5 years. And that's even when they're on the best meds and stents and getting optimal therapy. So what can we do to fill in the gap and treat these folks? I mean, I'm going into heart failure transplant next year. We all know about transplants and VADs being options for end-stage cardiomyopathy, but how can we prevent people from getting to end-stage cardiomyopathy? And I think cell therapy has a big role to play in doing that, to preserve cardiac function and prevent the remodeling that happens. So just to take a brief step back, because it's been a while since some of you, I'm sure, have thought about this stuff in med school. So, of course, the stem cell we all started out as is embryonic, and those cells can become any type of cell in the body. But it's important to note that what I'm going to be talking about today is adult stem cells. So there's lots of genetic and ethical issues that I get to bypass because we're talking about adult cells. So everything from your hair that keeps on growing to, as I mentioned before, your intestines that regenerate, to, of course, famously our blood cells, which are turning over all the time. These are the types of stem cells in our body, and all worth study, because for the longest time we thought that the heart didn't have stem cells and it was a terminally differentiated organ. Well, it turns out the heart does have its own resident stem cells, but for all intensive purposes, they don't have the regenerative capacity to take on the large task of regenerating after big infarcts. Another somewhat newer player on the block within the past 10 years is iPS cells. This is another way to get around having to use embryonic stem cells, is just taking skin fibroblast or a similar type cell and reprogramming it with either transcription factors or siRNA or various other strategies to get them into more pluripotent stem cells. I'm not going to talk about them any more than to just introduce them, but just so you all know that there are multiple types of cells that are candidate cells. So there's lots of issues with cell therapy, and we'll touch on most of these. The first is who would benefit from cell therapy, which types of infarcts, which types of patients, what type of cells should we be giving them? Should we be giving bone marrow cells, stem cells from fat, cultured cells? When should they be given? Of course, the heart is a dynamic and very active tissue following an infarct. So is earlier better? Is it better to let the tissue sort of cool off and deliver cells several hours to days later? Or can cells be used in chronic stable cardiomyopathy? Some of the biology, I think it's important to think about why stem cells would work and the mechanisms behind them. And then we still have some fundamental questions on, dosing. And do you need to give 1 million cells? Do you need to give 1 billion cells? How should you isolate them? How should you prepare them? There's issues with immune response, rejection, having to use foreign serum to grow cells, and so forth. So there's a lot. I just present this sort of as a laundry list of some of the big hurdles that that might partially explain why the development of our actual therapies have taken a while. So let me just go over some of the cells that have been studied. So by far and away, the most numerous cells that have been studied in probably now thousands of patients are just crudely purified bone marrow mononuclear cells. It's important to note that only a small percentage of those cells are stem cells. Also, we've studied mesenchymal stem cells. That's a specific type of cell that's found in bone marrow and fat and other tissues that has a lot of interesting properties that we'll talk about. Endothelial progenitor cells are another candidate cell type that's been studied. There's cardiac progenitor cells. These are c-KIT positive cells that reside in the heart itself that can be isolated and expanded in cultures. I mentioned the inducible pluripotent cells. And then there's what I would get into as sort of like the grab bag. So people do mixtures of cells or even create things like hybridomas. And so there's a lot of sort of various ideas that are in development, but these are sort of some of the basic types that we'll talk about. It's important to think about where the cells are coming from. So autologous cells are where the donor is the recipient. So a sick patient gets either fat harvested or bone marrow harvested, and then the cells are expanded, processed in various ways, and then given back to the patient. Now, the nice thing about that strategy is that, well, the cells are native from the patient, so there's no issues with rejection or supply. Usually you can get a high number of cells. But it's also important to note that these are not necessarily young, healthy donors if it's the patient themselves. So they have a lot of comorbidities. They've had a lot of stressors biologically throughout their life, and so their regenerative capacity is diminished relative to a, let's say, young, healthy 20-year-old who could donate in the other way, which would be allogenic. If you think about a blood transfusion, you have a similar matched donor with a similar blood type, and you won't reject or have immune issues if you match it correctly. So this would be sort of the analogy there, is that you would have donors and you would have a cell bank, and if someone had an infarct, you would just order cells from the cell bank and then have them already ready to go and then deliver them however you see fit. So that's the source. One of the things to talk about and go over is sort of what's the goal of therapy. So it used to be, we would hope that the holy grail would be, well, we need to regenerate cardiac myocytes. We know that that's what's lost, and so we need to have stem cells that turn into cardiomyocytes. As we've gone throughout various basic and clinical studies, we've learned that that's probably less important of a goal, and stem cells turning directly into cardiomyocytes probably isn't as important as just creating a healthier milieu in terms of apoptosis, immune stressors, oxidative stressors, and so forth, to promote blood vessel growth and just a happy environment to keep existing heart tissue alive, not necessarily turn stem cells into cardiomyocytes. I mentioned timing, and we'll talk about that a little bit later. And then with various delivery methods we'll get into, it's important to note that, you know, you can give 1 million or 100 million cells, but only a very small percentage will stay in the heart. And so there's implications there, and need for other strategies of delivery in terms of either catheter or non-catheter based methods, biomaterials, patches, sheets, and so on and so forth. And then in terms of, even if you've decided on a cell type, there's still multiple things you could do in terms of preconditioning cells or treating them with various growth factors, manipulating them with gene therapy. Lots of things you could do in theory to improve the stem cells that you would want to deliver to enhance their chances of repairing the heart. And then one issue that we don't really think about a whole lot, but that has come up in my research, is not just thinking about the cells you deliver, but also thinking about the host that they're going into and what factors in their immune system and in their heart would influence the response to therapy. So just to get a little bit of a definition for mesenchymal stem cells, these are cells classically isolated from the bone marrow. They also come from adipose tissue. You can get them, though, in most other peripheral tissues. They can be found in perivascular tissue. They can be found in placenta. They can be found in lots of places. They're mononucleated cells. They actually stick to plastic, which is very handy if you're trying to grow them, because you can just do a bone marrow aspirate and have the right isolation protocol, and they stick to plastic and other cells don't, so that's handy. You can select for them with certain media so that you get a relatively pure population. And then you can see some of the cell surface markers that they express. Classically, if you want to test them in culture, you would have various protocols to make sure that they can differentiate into adipocytes, chondrocytes, osteocytes, and myocytes. But they can also differentiate into cardiomyocytes and nerve cells and so on. It's important to note that they are stem cells, so they're expandable, and they can differentiate, as I said, in the different cell lines. And they can be autologous, so that's important because you don't have donor-recipient mismatch issues. But they can also be genetically modified via virus or small interfering RNAs or various other mechanisms genetically. And it's also important to note that they're immunoprivileged. So what that means is they express different MHC-type receptors on their cell surface, so they won't get rejected as easily as other cells in foreign tissues. So how do they work? Well, several different hypotheses, and probably all of these happen simultaneously. So this type of cells I mentioned can differentiate not only into heart, muscle tissue, or cardiomyocytes, but also into vascular cells, which, as you know, if you have ischemic cardiomyopathy, blood supply is an issue. So differentiating into endothelial cells and vascular smooth muscle cells is important in reestablishing healthy tissue. But more and more, we've come to realize that direct differentiation is actually less important than a lot of the paracrine effects of these cells. And paracrine, obviously, if you remember from endocrinology, just refers to soluble factors that stay local and help the surrounding tissue. Most of the time you think about growth factors, but also cytokines and other secondary messengers are important. These, for example, insulin-like growth factor 1, stromal-derived factor, tetrahydrobiopterin, there's lots of growth factors, and you could spend an hour talking about any one of these. But those overall act to, in general, decrease inflammation, decrease apoptosis, decrease oxidative stress, and decrease inflammation. And from all of that, you can protect the heart from insults and hopefully prevent adverse cardiac remodeling and promote repair. So here's our sort of hypothesis about how these mesenchymal stem cells could work. It's important to understand some of the natural history of what happens after an infarct. So clearly, occlusion in blood vessels is part of the initiating insult. And then, of course, any tissue that is served by that blood vessel will become hypoxic and have an acute metabolic and oxidative insult. This is accompanied by, obviously, tissue necrosis and apoptosis, but also these are supposed to represent inflammatory cells, and then vascular cells that are also compromised. And then over time, our body's healing process is to, of course, form a scar. If we don't form a scar, horrible post-MI complications like free wall ruptures or VSDs would occur. So it's important that within the first several days, a nice collagenous scar is starting to develop before all the tissue dies and causes rupture. So that's sort of the natural history. How could stem cells avoid that? Well, again, either injecting or having some method to deliver these cells. And I've depicted this here sort of as a magic fairy dust of paracrine factors. Again, growth factors, cytokines, and what have you. Acting in three different major ways. One, to protect myocytes directly. Two, to promote neovascularization or blood vessel formation. And three, to alter the immune system to sort of dampen some of these pathologic inflammatory responses that occur to cause adverse remodeling. And so ideally, given in the right time and the right dose by the right mechanisms, these stem cells would minimize any scar formation while preserving myocardial function and preventing sequelae of ischemic cardiomyopathy. So the hot topic of timing, as I mentioned, right after an infarct, there's a very high pro-inflammatory environment over a course of several days. And if you look in several models, both autopsy specimens or getting into animal models, there's a fairly reproducible time course of what happens in terms of macrophage and neutrophil infiltrates, followed by differentiation and a predictable course of various subtypes of macrophages. And that comes along with fibroblast activation and scar formation, and then sort of the cleanup of all the dead tissue that occurs. So it starts out as sort of a pro-inflammatory environment, and then there's a switch in the cytokine and immune cell profile such that there's actually an anti-inflammatory and pro-fibrotic environment that occurs. So just briefly touching on some of the methods that have been tried to deliver these cells. Obviously the most simplistic one to think of is just simple intravenous delivery of a bunch of cells and just hoping that a certain percentage of them will land in the heart and cause protection. That doesn't work all that well because, as I mentioned, only a very small percentage, less than 1%, would probably stay in the heart that way. Better strategy, and what is often used, is intracoronary delivery. So the idea is that you would have someone with a large STEMI in the LAD, for example, and you would immediately, of course, as per usual care, go to the cath lab and deploy stents and do your routine STEMI management. But then afterwards, either with an off-the-shelf product or with autologous cells that you would harvest at the time of STEMI, you could deploy a delivery catheter down the same infarct-related artery. You could use a balloon proximally so that you know that the cells continue downward to the affected tissue and don't just flow back the wrong way, and you can deliver cells that way. Another method is you can use catheters that go towards the border zone of the infarct through the endocardial side, and you can even use fancy NOGA catheters and use electrical mechanical mapping to try to figure out which parts of the heart are not contracting and having electrical signatures such that you deliver to the border zone. Border zone being in between normal tissue and infarct tissue, where your regenerative capacity and your ability to limit scar is greatest. And then finally, one delivery method that we've worked on a little bit in the Taylor lab, and Rebecca's continuing to work with as well, is different biomaterials to adhere cells either in sheets or patches onto the epicardial surface, and also take advantage of the paracrine effect of these cells to limit remodeling. So I want to start by, I don't have time to present each of these studies individually, but just in meta form, these are some studies that have been done on relatively crude bone marrow-derived mononuclear cells delivered, for the most part, by the coronary approach, as I mentioned, but sometimes given IV or given by myocardial injection. The net effect of all of this, as you can see, most of these studies cross and don't have statistical significance on their own, but in aggregate, if you look at all the cells, you have somewhere around a 3 to 4% increase in your EF as a result of delivering these cells. Now that might not seem like much. It's probably equivalent to some of our medical therapies, to be honest, but there's actually a debate in the stem cell world right now in terms of how do we best do surrogate endpoints, and is global EF truly the most important outcome to be measuring? Obviously the hard outcomes like death, MI, stroke, need for revascularization, those would be more important. But when you have all these small studies where they're looking at, dozens to a few hundred patients, they're just not powered to look at those big outcomes. So we're unfortunately forced to use surrogate markers. So at least from a global EF scale, you might get between 3 and 6% improvement of EF. If you select patients appropriately, you might do a little bit better. So this is a study I did want to pull out of that group and explain a little bit in detail. This was the Repair AMI study, and I pick it because we actually have some 2-year follow-up data from it. So as you can see, similar to other studies, In the arm where people actually had a low EF as a result of their MI, so it was below the median and it was under 50, they did see an improvement in their EF, whereas people that had preserved ejection fraction, if you give them stem cells, their ejection fraction doesn't get any better. So these cells were given 3 to 7 days after an infarct. They were given by the coronary route. And again, it's important to know that this study was just 200 patients and wasn't powered for outcomes. However, in the 2-year follow-up, while none of the individual endpoints, death, MI, revascularization, or heart failure hospitalizations was statistically significant, if you looked in aggregate at combined endpoints, there was a trend and actually a statistical improvement. Again, not powered for, these types of outcomes, but very promising signal, and certainly safety-wise has met that bar. Flipping over to the type of cell I work with MSCs, there's been a handful of studies as well with MSCs. One that I'll highlight here was just in 50 patients that had low to reduced or borderline normal EF. These were cultured MSCs, again given by the coronary route in the infarct-related vessel. And there was a little bit of improvement in EF, again, as the other studies had shown, particularly in the subset of patients that had an anterior MI, an LAD or anterior MI. They seemed to benefit in terms of EF the most. And interestingly enough, arrhythmias were decreased. And I think part of that, as we know from atrial fib, a lot of arrhythmia is driven by metabolic and inflammatory derangements. And so I think obviously the same would be true in ventricular arrhythmias and ischemia in general. So again, having these cells to calm down that harsh environment after an infarct would, it appears, decrease arrhythmias, VT in particular. And this was follow-up and at 6 months making statistical significance for here a 7% improvement in EF. Of note, though, the placebo group had about a 3% improvement in EF. So here's another study looking at MSCs, but this time derived from fat tissue. So these people got liposuction at the time of their STEMI, and 24 hours after they were processed and given back, again through the infarct-related coronary artery. And this was just basically an imaging study, but they do show decrease either by SPECT or by MRI in the scar area. So just a few words on safety. When the field started and we were using embryonic cells in animal models and we were using primitive myoblasts, arrhythmias were a big concern, tumors were a big concern. The adult cells from the bone marrow seem to have less of a concern. So thousands of people have gotten MSCs, and the only people who got cancer were people who already had a cancer or they had a cancer in remission that came back. So there were no new cancers from giving MSCs. The only thing that made statistical significance in terms of side effect profile more than placebo was actually a fever, which, like another transfusion, would be expected almost. So getting a little bit more into the weeds, into the immunobiology and some of the stuff I'm interested in. It seems that MSCs do multiple things to the immune system. So for those who, it's been a while since you've had immunology, and I count myself in this group. T cells obviously are a big branch of the immune system that direct just about the whole show of the adaptive immune system. So T helper cells coordinate both B cell and T cell killer responses. And you have branches of the T cell arms that both turn up immune responses and turn down immune responses. Dendritic cells are important antigen-presenting cells that activate the immune system peripherally. Macrophages are, of course, tissue immune cells that also coordinate a lot of the immune response. And neutrophils are, of course, our innate immune response to infection and acute events. They can be mobilized very quickly in huge numbers, but they're not that smart. So, and then NK cells also mediate a good amount of Rebecca's laughing because she studies neutrophils. So I won't bash on them anymore, but NK cells are another killer arm of the immune system that's, you could simplistically think of as bad in the setting of post-MI. So the bottom line is that MSCs in a favorable way turn on immune responses that would promote fibrosis and turn off immune responses that would cause tissue destruction and post-MI adverse remodeling. It's important to note that not every immune system is the same. As we know, people with heart attacks are not just isolated heart attack patients. They have diabetes, they're elderly, they have abnormal immune systems. And so the T cell responses are going to be different in an 85-year-old diabetic compared to an otherwise young and healthy 40-year-old, for example. So back to some of the stuff I've done. When I first came into the lab, one of the things I did was trying to see what materials and injection methods would be a good way to deliver these cells. This was sort of an extension of Dr. Levitt's work. She had helped develop some of these biomaterials and encapsulation strategies to deliver hearts and do a good job in nude rats at improving their left ventricular systolic function after MI. And I was a little perplexed when I started in the lab. I actually used rats that had a full intact immune system with rat MSCs. And I noticed that injecting these cells by themselves in these animals with an intact immune system did a pretty good job, whereas previously in nude rats, the cells needed more help. They needed biomaterials, they needed some other support. So that was a difference that I decided to pursue and try to tease out why. I should note that nude rats are nude because they look nasty and they don't have hair, but also they lack a thymus and they lack T cells. So that becomes important in the story. So just so you guys can prove that I'm not making up numbers, let me play. So this is after LID ligation. You can see characteristic thinning and akinesis here. This is MRI of a rat. And sham animals, so they have not had an infarct, you can see obviously very good ejection fraction and LV systolic function. And this is animals that have been injected. They got the same LAD ligation, but these two animals were injected with MSCs, and you can see their EF remains preserved. Miracle of miracles, unfortunately. This is a month after their infarct. So, and I should say, at least for my delivery method, I only did one open chest surgery in the animals. So the cells are delivered within 5 minutes of the infarct. So I wanted to tease out, because of the difference we noted between animals with and without a thymus, I wanted to tease out what role T cells would have with MSC. So I designed a relatively simple 2x2 study where I would have intact animals and give them no cell therapy just to see what the course of the MI was. And then alternatively, they would get either MSCs or T cells or both. And so I could tease out if the MSCs worked or if MSCs required T cells to work. So very briefly, I'll tell you that in the animals that have an intact immune system, if you give them stem cells, the stem cells work. They repair the left ventricular systolic function compared to the MI. But in animals that lack T cells, if you give them MSCs, they do not see improvement in their systolic function. However, if you give them MSCs and T cells, they recuperate their LV systolic function just about to the level as the other animals that had a native immune system and received MSCs. And just as a control, if you give animals T cells alone, it does not help their MI. Similarly, if we look at, this is cross sections, and you can see blue here is a collagenous scar after infarct. Similarly, in the animals with the intact immune system, if you give them MSCs, you have great improvement in scar formation, or less scar, I should say. And in nude rats, giving them MSCs alone doesn't seem to improve the scar all that much, but if you give them MSCs and T cells together, you get great improvement in the ischemic remodeling. So I wanted to dig a little bit more in detail. So I had actually Eric and Anita help me with this. Was to look at, well, what's going on in the hearts over time when you give stem cells? What happens to the T cell populations? And so this is an ongoing project, but this is normal intact animals, and they get an infarct, and then at various days we digest the heart and isolate cells and see what kind of cells are there. So what you have to do is cut out the heart and actually hang it on this perfusion setup where you have warm solution going through that actually has enzymes that digest away the heart, and then you can sort the cells and tell what type of cells are there. So it turns out that if you give a rat a heart attack, there's a lot of leukocytes that infiltrate over the first week, and that's to be expected. It's a very inflammatory process having a heart attack. But if you give MSCs, you have a big blunting. Sorry, I don't think these are labeled, but you have a big blunting here. Giving MSCs reduces the total amount of leukocytes that have infiltrated the heart. So you've slowed down the inflammatory process. Looking at a specific type of T cell, a regulatory T cell, that percentage, this is a cell that can calm down the inflammatory process, that percentage of cells is greatly increased by giving MSCs. So again, there seems to be some interaction between MSCs and T cells in a protective way that we need to learn more about. So just to briefly summarize my studies, MSC delivery by injecting into the myocardium improves function, reduces scar formation, but the benefit requires a normal immune system with T cells. As I just showed you, MSC therapy decreases the number of leukocytes and increases the percentage of Tregs that are in the heart post-infarct. And it's important to think not just of the stem cells you're delivering, but the host that they're going into, because their immune system will dictate how these cells respond and how they heal the heart in ways that we're only just beginning to understand. So that's sort of just the brief basic and translational science. I wanted to, for people that still argue that this isn't going anywhere, I wanted to remind people that now, instead of sort of preclinical and phase 1, a lot of these stem cell studies are phase 2 and now starting to be phase 3. So we are getting somewhere, even though it's taken decades. So just to highlight a few that are happening, these are all on clinicaltrials.gov, so this is publicly available information. This is a study for cardiopoietic cells, so these are MSCs that have been conditioned in culture. So this is an ongoing study. Here's another one. This is a combination, so this will be a 2x2 format where people get either MSCs or the c-KIT positive cardiac native progenitor cells, or both, and looking at that in ischemic cardiomyopathy. And then there's going to be a large study in Europe, the Bammy, with I think 3,000 people they're trying to enroll, using bone marrow derived cells. Again, these are the cells we have the most evidence for because they've been given to the most people, but they're very crude and they're a very heterogeneous source of cells that are being delivered. So hopefully by the time the next presidential election comes around, we'll have some information about in larger outcomes-based studies what we'll have with these. So one thing we have learned in the past 10 or 15 years is that stem cell delivery, at least with these adult cells, is very safe. The initial signals are very promising. We don't have good outcomes data, and there's lots of variables that we're still trying to optimize to get these cells to stay where they need to go, to have the immune system act the way it's supposed to act, and to optimize our timing and our doses and our delivery methods. I think animal models and basic science are really important because I think obviously treating 1,000 rats is a lot easier and quicker than treating 1,000 people. And so I think heading back to the bench and answering some of these basic, from my perspective, immunobiology questions helps us guide our therapies and design our trials going forward. So I'd like to thank everyone in the lab and all of our collaborators. And at this time, I will be happy to take questions, if I have time.
Tim Henry's group from California reported an update on stem cells recently of benefit. Can you enlighten us about that? This is a group out of California.
Yeah, I am not familiar with the particulars of that. Do you have a particular question or?
For that study, but
yeah, I'll have to look at that. That would be interesting for a journal club.
Jane, let me ask and see if I kind of understood what you were talking about. You were saying that part of the effect, or a major part of the effect, is a paracrine effect, that the stem cells are releasing something that changes the environment.
Mm-hmm.
And that makes, and you do this, only give this in the margins, that in the center you can still have a scar, which I didn't quite see in your examples of any. It looked like the ones that got this stuff had a totally revitalized myocardium. And I didn't, but then you're saying if you give it in the margins, you protect the margins, you still got some area that you're going to lose. And then you've also, your timing is important, that you start out with a anti-inflammatory or an inflammatory response followed by a fibrotic response. Is
Correct.
that right?
So I think one of the discrepancies that unfortunately the interventionalists don't often get to deal, or the surgeons for that matter, is that I literally have the opportunity to see the heart blanching and watch the infarct from the second it starts. And so the fact that I'm delivering stem cells within 1 or 2 minutes of tying off the coronary, I think that might explain why I have such good scar resolution. Certainly in animal models, I haven't done it, but other people have done sort of ultrasound-guided, echo-guided injections at various time points to try to tease out the timing issue of when you can intervene. And certainly the earlier one would think would be the better, so long as the hostility of the environment can be overcome by whatever cocktail you're delivering with cells and growth factors and otherwise. Yes, Rebecca.
Jane, that was awesome. One question I had was about the mechanism of action of your T cell restoration, because you're basically giving T cells back in an adult animal. Those T cells were trained and educated in a different animal, and they may be actually reacting to many different antigens. So what do you think they're doing?
That is a great point. These T cells are not only trained in another animal, but they're being given to an animal that's never seen a T cell in its life. And so how an immune system that grew up away from T cells is responding to these is a completely fair question that has not even been begun to be addressed. So the short answer is I don't know.
Jane, I'm sorry. Before we get rid of our electrophysiologist, how long did it
I talked
take?
about arrhythmias.
Yeah, what kind of time period are we talking about with the human studies? If the arrhythmias are better, if the LV function.
So usually they're given within the first several days. There was a later trial where cells were given 2 weeks later, and the benefit wasn't there. So I think quick intervention, which is an argument in my mind for a donor or allogenic stem cell bank. And so in the cath lab, literally after, when you've got your Impella and your stents and all the interventional stuff going on, it's thinking about within that first 24 hours of the STEMI, calling the blood bank, getting the cells, and going back to the cath lab to deliver them, if that's the approach we decide, or deciding on packaging them in other biomaterials and giving them in other ways.
And when the arrhythmias got better, was that sort of days also, or something?
Yeah, I think that was in follow-up, and I believe that was also over the course of several days. But I think it was sustained. I would think it was sustained. Obviously, if you prevent scar from forming, you'll prevent that arrhythmic scar also. So I think that was sustained in that study.
And is the fact that you give it intramyocardial versus giving it intracoronary and all, is it clearly proven that you can get to better places, or?
Well, so I don't think anything's been clearly proven. I think all three, so epicardial, endocardial, and through the coronary itself, have been tested, and there's pros and cons to each one. Certainly, your success in revascularization would dictate how, if you have a CTO, for example, you're not going to be able to deliver that through the coronary unless you open up the CTO. So I think having multiple approaches in development makes a lot of sense, at least for now. Certainly things like patches and biomaterials where the cells are physically stuck and they can't be washed away by the contractile action or the circulation in the heart would be of benefit.
So Jane, trying to think of some intelligent question to ask you. So I noticed on your MRI you like delta D. You like any question will be all right. So I noticed you like delta D to measure that. You use delta D, change in diameter.
So
I guess it makes all difference in the long axis because you.
So
you
I
looked at them all
showed
way
the
down.
short axis, but in the calculations we actually do the whole 3D volume. It's a volumetric ejection
Ejection
fraction.
Yeah. So you gave these stem cells how to your animals?
Mine were directly injected, so I picked 3 to 5 places in the border zone. So it's the area where I see the blanching and I see the color change of normal red beating tissue to the white purple ischemic tissue right after the infarct, and that's where I inject on the anterior surface of the heart. Not at the apex, just right at the ring that is ischemic.
Yeah. I thought that that Arshad's group gave the stem cells on the 7th day. There's something magic about that.
I think there's a lot of factors that we're still teasing out to go in it. Certainly by 7 days, you have a quieter environment in terms of reactive oxygen species, and you're starting to get that fibrotic scar form. Obviously, if you don't get a scar, then you can have issues like free wall rupture, for example. And so I think your percentage of engraftment or your ability of the cells to be in a less hostile environment might be better, but the trade-off is that you've already got some scar development. So those, as I said, there's so many factors to try. I think doing more trials in animal models makes sense, just sort of to rationally design clinical trials in humans.
Yeah, that was very instructive, even for someone who doesn't deal with this area of research. Because I can tell you, it's probably almost once a month a patient of mine will come and be like, "So what's new with like stem cells? Like, give me the latest on stem cells." And you usually just sort of, no, but now I can answer their questions. So.
Well, and I think it's the Wild West as well, because you'll hear people go either out of country or, quite honestly, even in country to clinics of dubious quality, of cell products of unclear and unregulated, and who knows how they were processed, and they're just injecting them into people, and who knows if they're going to have strokes or emboli or other things. But
Clearly an area where a lot has been promised, to the lay public, it would seem. One thing that raises a lot of good points. One thing, obviously, that comes up in this is the role of the immune system in the post-MI patient. I think, it sort of makes you think that could be a big area in future, post-MI patients, is tweaking the immune system, something that we haven't really tapped yet in clinical medicine.
I couldn't agree more.
How to whether or not, what the role of whether it's stem cells or immunomodulator therapy of some kind, and sort of the future of that. I think probably a generation from now, that may be a big part of what we do in these patients is, ramping up or tweaking or just shifting the way the immune system responds to these patients.
And certainly we already do that with statins and ACE inhibitors. We are changing that milieu. We just don't even have a great concept of the basic biology of how we're changing it.
So Jane, do you undo the ligation in the mice?
I do not. There is a whole separate literature out there of models of what's called ischemia reperfusion, and other people in our group or in our larger Emory group have worked on those models, and that is a different animal. And reperfusion injury, as you know, carries its own, at least acute, set of consequences that can actually propagate the size of an infarct. So while I don't study that model, I'm more of the typical Grady patient who waited 20 hours or whatever, and that artery is not going to be open again type model in these animals. But that's certainly a whole nother disease process, to be sure.
It really is remarkable to see, with the non-restoration of the typical coronary flow, to see those stem cells come in and remain viable. Obviously, in addition, have you looked at the biology, a biopsy of that segment of the tissue to see how the myocardium looks and any vascular supply to that area looks?
Yeah, so we know that if we stain for vascular, like small vessels, that the stem cells increase the amount of small vessel formation and neovascularization in the ischemic tissue. In terms of, I do have a lot of staining I'd like to do to look more in the pathology slides for specific immune cells. But we do know that the vascularization is there, the amount of apoptosis is decreased, and so on and so forth. I don't know if, Rebecca, did you want to talk more about ischemia reperfusion? I know that is an area of interest for you.
It's probably a whole nother talk.
Okay.
It is very different.
Great talk, Jane. Really enjoyed that. Very good.
Jane, do rats rupture their myocardium, and how does like MSC?
So, you know, I don't do necropsies on all of them, but in these animals, there is a little bit of a survivor bias. So it's a good infarct, and somewhere around a third of the animals die within the first 24 hours, often within the first hour or two. That's, you know, too soon to have to have enough tissue necrosis that you've had a free wall rupture. In the hundreds of animals I've done, I could probably only count on one hand the ones that died after, so in other words, day 2 to day 10. You know, most of them, if they're going to die, will die in the first hour to 24 hours. And so I think those are more acute cardiogenic shock or arrhythmia-related deaths. I've not seen the ruptures. Do other people working in the model have any other things to say? But it is a good infarct, and this is a survivor bias because, again, a quarter to a third of the animals die within the first day or two.
Maybe a light vest.
Yeah. Okay. Thanks, everybody. Thanks for coming.
The preceding program is copyrighted by Emory University.